Speaker Dr. Nishkarsh BANSAL.
Very good afternoon to one and all. Today I'll be presenting a case of red herring of Arcuate Scotoma. As we all know, glaucoma is a commonly ocular condition characterized by progressive optic nerve damage associated with elevated IOPs. However, certain conditions may present with similar findings, leading to diagnostic confusion. For example, paravenous pigmented retinochoroidal atrophy is a rare condition which can mimic glaucoma, especially when presenting with arcuate scotomas. So this case report aims to highlight a rare instance of PPRCA, which was initially misdiagnosed as glaucoma. Starting with the case details, a 58-year-old lady came for routine evaluation with 6/9 unaided vision improving to 6/6 and 6 on anterior segment examination when HIRIX grade 3 optically empty with early SIMC changes. IOP initially was 22 and 22 in both eyes, gonioscopy opening to scleral spur in both eyes, and on fundus evaluation 0.6 cupping with healthy NRR. After 3 years, patient visited again and IOP at this time was 20 and 19. Fundus evaluation done again revealed again same CDR 0.6:1 with normal findings and normal neuroretinal limb, but visual field revealed bilateral superior arcuate scotoma. Hence, patient was called for a follow-up, and on next follow-up, IOP was 22 and 22. And in view of the slightly higher IOP and visual field changes, patient was diagnosed with POAG and started on PG analogs. Patient continued the treatment for 2 years, and again after 2 years was seen. IOP at this time was 19 and 18 with same visual field changes. So over a total span of 6 years, no progression was noted in visual field findings nor even IOP levels. But on a detailed fundus evaluation, what was seen was surprising: pigmented accumulation along the retinal veins, which was accompanied by peripapillary and radial areas of retinochoroidal atrophy. So what is unique in my case that the scotoma noted on previous visits of the patient exactly matched the atrophic area noted on fundus examination, and no glaucomatous progression was noted in the IOP, visual field or disc changes. Hence, finally the AGMs were stopped and the arcuate scotoma did not progress. Finally, the patient was diagnosed with pigmented paravenous retinochoroidal atrophy. Clinical implication that it is a rare condition characterized by RPE degeneration, choriocapillary atrophy and pigmentation along the retinal veins. The retinal atrophy is characterized by loss of photoreceptor outer segments, outer nuclear layer and inner nuclear layer. It's a bilateral and symmetric condition with an asymptomatic presentation, generally non-progressive or very slowly progressive. Color vision is usually unaffected, and formal visual field testing may manifest scotomas. There is no treatment specific to PPRCA, and while the exact cause remains uncertain, possible etiologies include dysgenetic, dysgenerative, hereditary or inflammatory conditions. However, no systemic diseases have been identified. As of now, CRB1 gene has been detected with patients with PPRCA. Other than that, no significant study has been done for this. This clearly highlights a clear-cut case of red herring of arcuate scotoma, where the mind refuses to see beyond the glaucoma, and clinicians should prioritize a thorough evaluation of the entire fundus rather than just only on the optic disc findings to ensure accurate diagnosis and appropriate treatment decisions. And even while the optic nerve head assessment is critical, an isolated disc finding can lead to misdiagnosis, especially in conditions with overlapping features. I would like to acknowledge my teachers and my colleague for the same. No financial disclosure. These are my references. Thank you.
Glaucoma diagnosis as such should be a comprehensive one, which includes all IOP, fundus, disc evaluation, field as well as OCT.
Yes.
So this is very, if it's a case of POG, it will directly fit into it. So definitely with other findings as you have stated, peripapillary pigmentary changes, diagnosis is straightforward. So it should be a comprehensive one.
I think it's an excellent case and very well presented. And quite honestly, I've seen patients with healed choroiditis patches being diagnosed as glaucoma just because there was RNFL thinning in that segment. Nobody did a retinal examination, just an RNFL analysis was done and clear-cut red areas are there. So, and quite honestly, in my center also, a similar patient with PPCRA was being diagnosed. There was a good amount of diagnostic dilemma which perturbed us for a lot of time. And then we finally came to the diagnosis that no, this is not glaucoma, just some faint PPCRA.
That is what we have seen, that usually we'll see the disc evaluation, disc findings, and based on that we'll just diagnose as glaucoma.
So I think the biggest take home message is of course a comprehensive clinical examination, and your basics do not go away. If there is no damage to the NRR, labeling a patient as a patient of glaucoma should be avoided, or at least should be done with extreme caution. Excellent. Thank you.
Thank you.